Right. Well, thank you very much. I'm glad you've joined us. Let's get started. I do need to tell you that we have a cooperative agreement with HRSA. And so here at the Center for Optimizing Health, um, the contents of this webinar reflect the author, myself, Bree Watzak, and not necessarily the views of HRSA, the Health and Human Services, or the US government. So with that out of the way, let me tell you what we're going to talk about today. I'm going to go over quickly who we are here at the Center for Optimizing Rural Health. I'm going to talk about what we do and why I think that you might enjoy working with us. And then we're going to talk about how you can connect with us, the different ways that that would be possible. All right. So who are we? At the Center for Optimizing Health, we are a technical assistance center. And what we do is we provide three different levels of support. There's on-site, there's remote facilitated, and then there's the self-directed, and that's access to best practices, resources, and tools. And we provide targeted, in-depth assistance by subject matter experts. And what I mean by targeted is that we don't think one size fits all. We don't have a cookie cutter answer for you. And so we spend time getting to know you and your community and what you and your community need. And that's the sort of assistance that we offer. So that's what we mean by targeted. And what we do is we assist hospitals in their communities in broad strokes to address economic challenges, understand what your community needs are, resources, and we find ways to help you keep your healthcare local. Now, in case you're worried that we have a Texas-centric mindset, I do want to let you know we have a national advisory board, and these are rural experts that span the coast from east to west, and they make sure that we are aware of how things are outside of Texas, and they help us advise and make sure that we are applicable to anybody in the United States. And so our on-site technical assistance is for 5 hospitals each year. We get a new cohort every year, and then we have 25 hospitals that get the remote facilitated. I don't want you to worry that the Center for Optimizing Health is a startup. While we are in our 3rd year, we are housed within the A&M Rural and Community Health Institute, which we call ARCHI. And ARCHI has been doing rural outreach in Texas for over 16 years. So I just want to set your mind at ease that this is what we do. We work with rural communities, and we believe in access to healthcare. We have a team that will be working with you. And so I don't want to spend our hour going over bios for everybody, but let me tell you about a few of our team members. Our head of our team, our boss, is Dr. Nancy Dickey, and she is a family physician by training. I'm Bree Watzek. I'm speaking to you right now. I'm a pharmacist by training, and I'm the director of technical assistance. So you'll see me on webinars, echoes, phone calls. So that's kind of what I do. I'm also partnered with Dr. Jane Bolin, and she is a nurse by training. So we get healthcare, and we get healthcare in rural areas. We also have Andrea Brewer. She's our project director, and she's on the session with us today. And Andrea keeps us all on track and makes sure we get everything done that we're promised. And it's great. You'll be interacting a lot with Andrea as well. Also on our session today, you have Cassidy Avila, and Cassidy is the one that will be inviting you to classes, not to Echoes, that would be Kim Cassins, but Cassidy's the one that'll have the beautiful invites in your inbox, and she'll be working with us on the classes and the webinars. We also bring IT expertise. So we have Sam Stiegel, he's on here today. He helps us with the magic of our technical assistance, and Dr. Peter Yu. And then I want to also highlight Angie Alanis, and while she's not on the session with us today, she brings the public health aspect. So we have a great team ready to work with you. Let me tell you a little bit about the levels of support. So I mentioned them earlier. We have Tier 1, Tier 2, and Tier 3. And so Tier 1, those are the 5 hospitals each year that we're going to pick, and we will come visit you. So boots on the ground, we will be in your town, and we'll be talking. So I guess I should say pre-COVID, we would have community forums, and we would have multiple meetings and interact with community members. from your churches and your food pantries and your businesses and the all the different entities that make up your community. We'll see what that looks like after COVID, but we're still coming. It may look a little different. Our tier 2, that's the remote facilitated. And so we don't have a boots on the ground visit with you, but we will use all the technology at our disposal in order to get to know you and your community as well. And then tier 3 is the self-directed. Let's take a deeper dive and look into these. So tier 1. So our hospital cohort is for a year. And so we will have 5 hospitals each year where we go and visit and have that on-site visit, communication, meet with your community. And we do this, again, so that we don't have a cookie cutter answer. This is to help us learn about you and your needs and your community and how you're different. And so we'll have 2 visits. We'll come early in the year to get to know you and see what your needs are, your concerns. And then we'll come at the end of the year, and that's a great way for us to talk to your community about what we did over the year, let your community know what we've been working on. And it's a nice way to kind of wrap up our year of work together. What we do during the year, in between the visits, we have the ongoing technical assistance by the CORH team. And it's not just us. I know I showed pictures of the CORH team, but we are not hesitant to pull in subject matter experts. If you ask us a question and I'm like, we don't have that person, we will go find that person. And that's how we make sure we're meeting your needs. And so we talk about once a month. We'll have a phone call and we'll say, when we came to visit, we talked about these are your 3 highest priorities. This is the material we gave you or the assistance we gave you to start working on these. What roadblocks have you found? What else can we do? And so we make sure that we're progressing along our goals for the year. We also have mentoring through different online educational materials. We have webinars every month. And these are topics that our hospitals told us are important. So it's not a curriculum we dreamed up on our own. It's what you told us you wanted to learn about. So we have the webinars every month. The webinars are recorded, which is nice. So you don't have to drop everything you're doing and connect. We also have peer-to-peer mentoring, which we call Project Echo. And if you're not familiar with Project Echo, it was set up as a way of telementoring so that, well, it was set up clinically. And so clinically, what you found is that the telementoring is a way to get clinical knowledge from an academic medical center out to rural providers. And what it did is it saved miles and time for rural patients. They didn't have to drive in to the city. And what they found is through this telementoring, the level of care and the abilities of the rural providers increased. And so it works clinically. We took it out of the clinical aspect and took it to the C-suite. So we still have cases, we call them challenges, but we have the C-suite present a challenge over this is what I'm dealing with today. And you get a subject matter expert that talks to you through a lesson. And then you get peer-to-peer mentoring from the other hospitals that are on the session. And they're like, oh, I had that and this is what we did. So you know that it works. And then you also have the subject matter expert input. Our tier 1s also have access to a virtual quality improvement collaborative. We get together once a month for 4 months, and we learn the basics of quality improvement, and we also work on a project. And then there's online classes. And the classes we have this year are recruitment for retention, grant writing, marketing, and board education. And then we're rolling out the DASH benchmarking tool. Before you get worried that this is a lot of material coming at you, let me tell you that these are options. And the hospitals that have done the best within our program are those that divide and conquer. So that's what I would recommend for you if you're like, oh, this is too much, I don't have time. Divide and conquer. And so we'll tell you the webinar this month is by Jamie Orlikoff, and it's on trending and what's trending in healthcare and what's the future going to look like. That would be good if you can for the CEO. The Echo this month is on how to apply for the FCC grants for telecommunications. You should have your grant writer come for that, or your marketing person, or your CFO. Whoever handles your money should come to that one. We'll tell you what they are. The webinars are recorded, so if it's on board education, you can tell your board members, hey, I didn't make this webinar. It's pertinent for you. Please watch it during your meeting if able. So we strongly advise the divide and conquer. Additionally, divide and conquer. We offer all these different options to meet the needs of the most. If you don't need it, if you have a wonderful grant writer and you don't need to take our class, good for you. That's amazing. These are just opportunities that we have for you. Okay, so that's tier 1. Our tier 2 is exactly the same as tier 1. The only difference is there's no boots on the ground to come and get you. But we still spend a lot of time on the phone and over Zoom to make sure that we do understand you and we get to know you and your community and what makes you unique. So that's the only difference between tier 1 and tier 2. And if you're a tier 2 and you want to apply for the next year and go for a tier 1, you can. Our tier 3 is self-directed. And this means that we don't come visit and you don't have the echoes and you don't have the monthly phone calls in the classes, but you have access to everything on our website that's public facing. So that would be the webinars. And right now we're having COVID echo office hours every other Wednesday. So those would be available to you. Now those are available to the general public, yes, that are not in our tier 3. So what the difference is between the general public and tier 3 is if you're a tier 3 hospital, we know who you are because you sent us your contact information with the application. And that means that we can better notify you and stay connected with you about, hey, this webinar is coming up. Or we know you are interested in this class, there's an opening, let's talk about how this might work for you. And we're also available to schedule brief one-on-one assistance calls. So we've done that. Andrea's helped facilitate a couple calls from hospitals that weren't in our tier 1 or tier 2, but they said, hey, can we pick your brain about this, or what do you think about this? So that's kind of the difference between tier 3 and general public. Let's get into how you can become one of our hospitals. So we have the application information, and this is available on our website currently as a PDF. The portal will open June 1st, so I don't want you to go there immediately and start applying, but the PDF is available right now if you want to start looking, and I'm going through the PDF. That's what the rest will be. So the portal will be open June 1st to July 31st, and we reopen every year. So we have a new cohort each year. Now, who can apply? We have 2 requirements to apply: a hospital, or you were a hospital, and rural. And our rural definition comes to us from the from FORP. And we follow FORP's definition of rural because HRSA is our funder. So you go with the funder's definition. And so what they say is you can be all critical access hospitals are rural, and a PPS hospital, if you are defined by federal or state as rural, any tribal or tribal organization, those are also rural. And if you are in any doubt, we have the website for the FORP eligibility analyzer, and we suggest you go there and just see, am I rural? So that's our inclusion criteria: rural and a hospital. Now the exclusion criteria are if you are already involved in a HRSA technical assistance program that is more in-depth than us, and that would be the Delta region or SHRT, Small Rural Hospital Transitions Program. So those 2, HRSA says you're already getting enough help, this is not the best program for you this year. Now, if you are Flex or SHIP, you are eligible to work with us. If you are in any doubt, because I know our application windows overlap a little bit, and you're like, I'm applying for SHRT or Delta, but I don't know if I will get in, please apply. We work with HRSA once we have all the applications, and we do our due diligence to make sure that you're in just the one program, and we will work with HRSA to make sure you are in the program that will serve you the best. So any doubt, please apply, or you can reach out to us with questions. I want to let you know, as we talked about with the divide and conquer for the educational materials, anybody can submit the application on your behalf. So if you have friends that have time to do this for you, use them. We have had a grant writer submit on behalf of 7 hospitals. We have had SOAR, State Office of Rural Health, submit on hospitals that they had identified and that they thought would be good for our program. And we've had hospitals strongly encouraged, and their state hospital association worked with them on the application. So please Reach out to your friends if they have more time because you're busy with COVID, and have somebody apply on your behalf. We do estimate it takes about 60 minutes to complete the application. And that's why we have the PDF up there so that you can be preparing and you can have all your information that you can work with whoever needs to help you gather the information when you come in. And we designed this to give us an idea. If you're wondering, where did they get these questions? It's to help us select the best opportunities and technical assistance for you. So let's go over the application. There are 5 main sections. There's the health of the community, there's the community facility level of readiness to participate, level of vulnerability. We look at distance to nearby hospitals and health access points, and we look at partnerships. So those are our 5 sections. Section 1, health of the community. It's 10 points out of 100. And this is just the basic demographics of you. That's all it is. And when we ask for name and position and contact, that is the person we're going to reach out to and say, congratulations, you've been selected. We're coming to visit, or let's talk about how we can work with you. So that's the person you put there, is who will get the notification. When we ask about systems and paychecks, that gives us an idea of the layers involved with any change implementation. So that's why we ask those questions. And then we want to know if you're shrinking or growing, the average age, income, and industry, just what's going on in your community. Section 2 is community facility level of readiness to participate. So yes, the Center for Optimizing Health, we are the ones that provide the technical assistance, but this is a working program. So the webinars are very passive. You can sit there and just watch, but the echoes and the classes and the change management, that's all very active. And so we're looking for communities or facilities that are willing to work with us. Again, you can divide and conquer. It doesn't have to be one person on your end that does all the work. And I want to draw your attention to our caveat here. It says, note, for questions in this section, each hospital will be scored based on the level of effort and initiative, regardless of where you are in the implementation of the activities. So if you're applying in June and you're like, look, our community decided they love us so much, they're going to increase the taxes for our taxing district, and the vote comes up in November, please include that. That tells us how active your community and your community leaders are in sustaining you. You don't have to wait until November to let us know. You'll miss the application window. So we're looking at what you're doing, even if it hasn't come to pass yet. All right, so we're going to ask you on a Likert scale, what does your community leadership think about the need for your hospital to remain open? And community leadership, what we mean, it's your definition. So that may be your mayor, it may be religious leaders, it may be your city council, the school boards. It's who do you think are the community leaders where you are? All right, we're also going to ask about your hospital board. Does your hospital board, how do they perceive the need for you to stay open and a vital part of your community? And we're looking to make sure, we're looking for unity of purpose, because these are not necessarily disqualifications. What we're looking for with the unity of purpose is, how do we spend our time together? Do we need to work with your board so they understand the importance of access to healthcare? Do we need to work with your community so they understand how to best support a rural hospital? Or is everybody on the same page where you are, and we can just go ahead with change management and look at service lines and how to optimize where you are? So that's why we're asking these questions about your community, your hospital board, is just to see where we start. Okay, we will also ask about how your community members think about your hospital. And this is the general public. So what do they know? Do they know that it's hard to be a rural hospital in these economic times? Do they have any idea? Do they think there's a magic pot that pays hospitals every day to offer every service? What do they know? What do they think? And we're also going to ask about you, the applicant. How much has your concern changed in the past 12 months? And this gives us a sense of your urgency. And we want to know about your hospital administration as well, because that may be a different perspective than you, the applicant, or the board. And the last question we ask in this section is, if selected, are you willing to serve as a mentor in the next generation for the next cohort? And that's because we believe that there's a lot to be learned from each other. Lessons, the good, the bad, the ugly. So if we can call upon you to be a mentor, we would like to know that. Section 3, this is the big one, worth 50 points. This is level of vulnerability. And so we're looking at current and historical financial vulnerability. So historical we get from the University of North Carolina Shep Center. They have a financial distress indicator. And what we use that FDI for is to get a historical aspect of how financially vulnerable your hospital is. So that's the historic perspective. We also want the current perspective because we realize how much can change in 24 or 12 months even, or with COVID, 3 months. So we're going to ask certain things to get your current level of vulnerability. So we're going to look at quality and experience. We're going to look at operations, and we're going to look at some finance indicators. And we have the formulas in the PDF. So if you're like, how are they calculating that? We have the formulas there so you know, so we can compare all the same numbers. Please pay attention to this question. This is in the level vulnerability section. Please describe any extenuating financial circumstances that you have that aren't reflected in the questions we asked. We know that numbers don't tell the whole story. We know that. Please share your reality with us. This is your place to do that. If you say 2 years ago it looked great, we had 180 days cash on hand. Last year at this time it looked great. We had 60 days cash on hand. Today we have 10 days. That shows the urgency of the situation that may not be captured with just the numbers. So this is where you tell us how COVID's impacted your community, your hospital, or maybe it's not COVID, maybe it's something else that happened. Your leading industry in town closed and took away all the jobs that had insurance. This is where that type of information comes in. So please take advantage of the question and use it. All right. We're also going to look at distance from where you are to the next hospital. Sorry, this is section 4. And so this gives us a sense of where you are and what options are available to your community. So we want to know the next 3 facilities close to you. We want to know if you have partnerships with them, such as, oh, we have an arrangement for swing beds. They have the nursing home, but we have the swing beds and we share, or we have an orthopod that rotates between us. What partnerships, if any, do you have? Are they friends or are they competition? That's kind of what we're looking for. And then are you tracking where patients go? So your out migration, is this a loss of business, which might be altered, or is your out migration a coordinated division of skill that, while we have the cardiac rehab, but the cardiac surgeons at the other place, like we did this on purpose to coordinate and partner. So that's what we're looking, what your options are. All right, partnerships. This is the final section. Partnerships is worth 10 points. And so this is, are you standing alone or are you already working with others? So we want to know about philanthropic organizations you might be working with, or access to care organizations that you have in the community. And again, if you look at our little caveat at the top of the note, we want to know what you're thinking about, even if it hasn't come yet. If you're like, we have a big fundraiser coming in October, let us know that that's what you have planned. We're just trying to see where you are in the process. There is a memorandum of understanding. The PDF is already on our website if you'd like to look at it now. In fact, I would encourage you to do so. The MOU is on the landing page for the application. The PDF of the application, the MOU, and then frequently asked questions are there, which we will update as we get more questions. So the purpose of the MOU, looking at it now, is to minimize the paperwork phase and maximize the time we work together. So if you have any questions on the MOU, please reach out even before the portal closes. We would love to hear if you have questions or concerns. Most of the questions we've gotten in previous years were, could you change one word or something? In essence, what the MOU is it has our Texas A&M collaborative agreement legal phrasing. But the important part for me is Appendix A, where it says what we will do as a Center for Optimizing Rural Health, and then it has what you will do. And essentially what you will do is provide us with information that we ask for so that we can help you. And what we will do is provide technical assistance. We will protect your data. We will not share your data, and we will give you reports and recommendations. So it just outlines how we protect, again, because we're going to be asking you for some of that financial information, which you might feel sensitive about. It just lets you know that we're not freely sharing your information. So that's what the MOU is. We also have a press release option, and the reason we included this is because we are so excited to be working with you, and we would love to send out a blast with all 30 names. But we understand that your community may not understand why you're getting help. And we've had some hospitals tell us, if you say this, our community will think we're closing and they'll drive to the next town and it'll make us close faster. Don't list us, just say we are a hospital in Texas. So this is where we respect your reality. If you just say, yes, please put my name, I'm going to capitalize on this so the community knows what I'm doing, or you're like, they just don't get it, we're not there yet, please just list us by state. And that's why we're asking that question. That is the entire application. So it is not designed to be painful. We acknowledge how many hats you wear when you're working in a rural hospital, and we're trying to ask enough questions that we have a good idea of who you are, but not be a burden with the questions. So as far as next steps, oh, and I do need to tell you about the application portal. So we didn't want to create a portal with a name and password because that's one more thing for you to remember and one more thing for you to set up. So the good thing is there's no login information. The bad thing is because there's no login information, it does not save your work. So that's another reason for the PDF. If you, when we get the editable PDF up there, if you want to type in all your answers and then cut paste, the portal will time out if left open for too long and you'll lose your work. So we recommend you have it all ready to go, and then you just cut and paste and fill it in on that. Okay, so next steps. Our portal opens June 1st. It will stay open until July 31st, and this allows us time to reach out to everybody in August and let you know what tier you are. And then we will work with you for a full year, so September 1st through August 31st of 2021. What we've been doing with our hospitals is once we've worked with you for a year, we put you in an alumni cohort. So it's still more information than you would get in the general public, but it's not the intense technical assistance we have been providing during your year. Please look at our website for new materials. In the meantime, we have webinars every month. And so the next one we have is on May 26th at noon. Jamie Orlikoff, Trends in Healthcare. He's an amazing speaker. I highly encourage you to watch that if you can. You can follow us on social media if you want to know what we're up to. So we have our Twitter and LinkedIn account. And the next COVID-19 Office Echo Hour is on the 20th, and that is Wednesday morning.